I'm Steve Kossor. I founded the Institute for Behavior Change, and we've been doing BHRS. Actually, I started doing it the day I got licensed back in '81, where I had one of my supervisees who didn't have to, at that time, have 15 graduate credits in order to do BHRS. So I had somebody come on and work with me, and they had a bachelor's degree, and they went into a kid's home and school back in '81, and it worked like a charm. So I know from 30 years that BHRS is, in my opinion, the only viable way to deliver mental health treatment to children that works. So I'm going to show you a bunch of evidence about that. But let me introduce it by saying this. We're all familiar with the idea of thinking outside the box, right? If everybody thinks that's what the box is, it's a 4x4 square, then what happens if you're thinking out here? Managed care is going to say, hey, that's outside the box. And rightfully so, because that's what they understand the box to be. But if the box is really that big, and you're here, are you outside the box? No. But the insurance companies think you are, and that's the problem. The box really, really is twice as big as this, and I'll explain to you why. Federal law. 42 Code of Federal Regulations, Chapter 4, Section 438.210, and this is a quote. Services must be sufficient in amount, duration, and scope to reasonably achieve the purpose for which they are furnished, period. If that's federal law, and that's the Social Security Act, the Medicaid statute, the EPSDT regulations embedded in it, that's a civil right. So if you're impaired and a diagnostic evaluation is done by a licensed practitioner of the healing arts recognized in your state, then you're entitled as a civil right to treatment that is sufficient in amount, duration, and scope. We're going to sing this before we're done. All right, to reasonably achieve the purpose for which it is furnished. Who determines the purpose for which the treatment is furnished? There's only one answer to that, and that is the clinician who examined the child face to face and prescribed it. There's always a certain amount of disagreement in any professional group. The bottom line is that in every single federal court case since 1967, the court has ruled that only the licensed practitioner who personally examined the child determines the purpose for which the treatment is intended. It's any licensed practitioner of the healing arts, which can be a psychologist in Pennsylvania, a medical doctor. Some states allow it to be a licensed clinical social worker. What I created was BHRS in a wraparound cup. I call it effective treatment in a wraparound cup. And basically, here's why. This is an analysis done by a guy named Mark Varsella, who's a graduate student at Immaculata, a graduate of Villanova University. I hired him as a senior research analyst because the guy's gifted in terms of his understanding of SPSS and statistics, and he's got access to all these characters at Villanova and whatnot. And I said, Mark, here's a database. It's got over 1,000 treatment records in it going back to 2002. Talk to your professors and tell me what it says. And this is what Mark found. We had 519 individual treatment plans, 167 children, with a total of 519 treatment plans. So some of the kids had multiple plans spanning several years of treatment. Most of the kids in this process have been finished with treatment after 3 years. Close to 90% are done in 3 years or less. But in any case, out of the 519 treatment plans assessed, we look at treatment goals in physical aggression, safety awareness, noncompliance with adult prompts, communication deficits, and socialization deficits. So you can look over here at the significance, and this is reproduced in your handout. The only treatment focus that did not result in a significant finding of improvement was socialization. And the reason for that is, in our scheme, we focus on physical aggression first. If that exists, it's inappropriate. It's got to be stopped, because that's a life killer. Second is safety awareness. If safety is impaired, that could be a life killer. Third is noncompliance with adult prompts. If you're not listening to those who can help you, you're pretty much doomed. So those are the top three. After that's communication. If you can't communicate effectively, you're going down a really low outcome life. So that's why socialization is not significant, because we tend to focus on socialization goals last. So the kid starts out, if you look at these numbers, the baseline mean is 6, 7, 7, 6. It's just under 6 here. So it's the lowest number to begin with. Therefore, it's going to require a higher outcome to achieve significance. This is Standard Statistics 101. But the thing to take with you is that all of these factors were significant. In other words, it doesn't matter if you're male or female, if you're above or below poverty, if you're Caucasian, African American, Hispanic, Indian, or Asian, BHRS works. Now we look across hours. The big question is, well, how many hours of BHRS works? And the answer is, it depends on the child's need. There are some kids who don't need any TSS, and out of our field, there were 80 who had no TSS prescription. We had 98 who had functionally 0 to 5 hours per week. We had 114 getting 5 and 10 hours per week. We had 72 getting 10 to 15, and then 15 to 20, 91. But we had 64 out of this sample getting over 20 hours per week. Now you might ask, how is that possible? The National Academy of Sciences, 2001. The American Academy of Pediatrics, 2007. The American Academy of Pediatrics, again in 2012, said that unless a child who has an autism spectrum disorder receives at least 25 hours of intensive individual treatment, they do not have a reasonable probability of symptom abatement. Period. 3 august bodies, no skin in the game whatsoever. They're just telling the truth. You have these 3 authorities, unimpeachable, saying that if you prescribe less than 25 hours of TSS a week, because that's the only intensive individual treatment within the BHRS model, you are under-prescribing the needs of that child. But how much does a typical child get of OT, PT, speech, and etc.? Maybe 5. Let's be generous. So what is the absolute minimum TSS prescription that is legitimate based on standards of prescribing for 20 years? 20. Minimum. So we start there and go up. Now, this is anathema to most managed care organizations because the box is that big. And that's where we have a problem. What I want to try to help everybody understand is that I don't have an adversarial relationship with managed care. I want to work with them, but I want to make damn sure that we're working with the box that is the correct size. About 62% of our client population has an autistic spectrum disorder. So the bottom line is there are some kids who are getting 15 hours of HIPAA therapy and various other treatments, and they don't need 25. But that's the process that a responsible clinician or MCO reviewer, in my opinion, needs to go through to decide if a treatment process is within the box or reasonable or unreasonable. You need to look at the risk factors, and I'll show you a piece that I put together. It's a BHRS continuation checklist that we use to determine whether or not a kid's even in the realm of possibility a candidate for BHRS. But once they are, then all of these other standards have to be considered in the prescribing or the reviewing process. If they're not, if the reviewer is applying a preconceived notion that, for example, if a kid's at level 4, that means he can get 20, but if he's at level 3, he can only get 15. If a managed care reviewer is doing that, they're actually violating the law. And that's why Appendix T does not have any particular numbers in it. Because let me just catch you up to this. The purpose of the Medicaid Act and the EPSDT mandate, in fact, is first and foremost to prevent the worsening of the child's condition. That's the top rationale for an EPSDT or BHRS prescription. The second one is to treat the existing condition and abate the symptoms. The third one is that they will maintain their functioning at a level which is commensurate with other children of the same age with comparable deficits. So if you meet any of those three criteria, you've met the medical necessity criteria in Pennsylvania for a prescription of BHRS. So now it's medically necessary. What's clinically appropriate? If he's on the autism spectrum, it's 25 or more hours per week. There's all this information out there, and the problem is so many prescribers don't understand how big the box really is. We got off on a wrong foot when we started calling BHRS Wraparound, as if there's a time limit for BHRS. There's no time limit. It doesn't have to be within 6 months. It's birth to 21. There's no mandatory titration system in there. There is in the wraparound model. We want to move to low-cost or no-cost services, and I'm a big fan of wraparound. I've been on the National Wraparound Initiatives list for 6 years. I like wraparound. That's why what I'm doing is incorporating BHRS into a wraparound model. It makes perfect sense. That doesn't mean wraparound trumps BHRS, because in my opinion, wraparound is a cup. It's an empty cup. You can wear it for a hat unless you put something in it like BHRS, some substantive treatment process. You're not helping. You may be able to move somebody through a system more readily with a wraparound empty cup, and that's certainly without a doubt the case. But Eric Bruns himself, one of the guys who coined the wraparound initiative, or at least has his stamp on it, has testified in federal court, wraparound is not a replacement for treatment. They are two different things. Wraparound is a means of managing or navigating, negotiating, whatever. BHRS is treatment. So what I've done is put BHRS in a wraparound cup, and it works. And here's the evidence. You notice over here in the significance column, 5 hours a week, it reduced the child's problems significantly for 98 of the treatment plans. But so did the 10-hour a week, so did the 15, so did the 20, and so did the over 20. The bottom line is, if it is individualized based on the child's strengths, weaknesses, and needs, it works. Do you drive a tack with a sledgehammer? Of course not. That's inappropriate. But nobody should tell you to use a toothpick either. You want to have the punishment fit the crime, the cost hit the benefit. I mean, all of these things need to be in balance. So who determines what the correct balance is? An informed clinician who is implementing standards set by national bodies. That's my opinion. All right, so here's efficacy of treatment across diagnoses. We're looking at autism. There were 269 of those, 143 with ADHD, and 107 with others. Again, no matter what their diagnosis, BHRS was an effective treatment program. There's no doubt that they tested lower consistently 500 times. That's not an indication that the treatment program caused it, but statistically the probability that this is a random or accidental association is very low. This is how we measure treatment. I call it a behavior record form. We have an operational definition of the target behavior. There's 3 different target behaviors operationally defined for any given child. Usually we're talking about, say, physical aggression. That might constitute hitting, kicking, and spitting. Those terms would be explicitly identified up here. And then we ask the parent once a week, Mrs. Jones, on a scale from 1 to 10, with these benchmarks identified, how frequently has your child displayed hitting, kicking, or spitting in the last week? And that number would be put in this frequency cell for that target behavior on that date. We ask the same question of the second target behavior and the third target behavior, so we have 3 frequency ratings each week, and then we go to the next level and we say, okay, Mrs. Jones, you said it was a 5 in frequency. But wait, let's be sure. Last week you said it was a 7. Has he gotten better? Well, no, it's about the same. Well, then it would be a 7, right? Well, no, actually he's a little better, so let's call it a 6. He's not that much better. So there's a dialogue. every single week to help the parent have a better understanding of where everyone else sees their child functioning as well as their own perception. So we have an effort to establish an understanding that is accurate on the parent's part. If the TSS is seeing the kid coming apart at the seams and the mother says it's a 2, who wins? The mother, because the parents determine when treatment is done. If she feels that her child has become manageable and our staff think he's really out of control, at some point you have to say, we have a difference of opinion. You either need another provider or you need to discontinue treatment because we can't keep this up. All right, so we do a severity rating using the same Likert scale. So the bottom line, after you got 13 consecutive weeks of this, you become eligible for inclusion in our database, at least 13 weeks. Typical treatment, 4 months, is about 17 weeks. We collect what amounts to a very robust repeated measures with a single subject with the same respondent over time. So it's a very robust way of getting a gauge on how the child's doing. And one of the concerns people have raised about this is, well, doesn't the parent have a vested interest in saying the kid is still sick if they want treatment? Well, there are some impaired parents that'll try to do that. But if the kid's behavior is benign, the TSS, our own internal records, are going to say, hey, he's benign, and we shouldn't continue to do this. If your perception is so discordant from our own, then it defines non-collaboration between your home and our staff. And we can't do BHRS where there's no collaboration. So we have that as a safeguard. The other occasion sometimes happens, the parents minimize and our staff know it's coming apart. Can we overrule the parents and say, oh no, your kid's going to get 10 hours whether you like it or not? Of course not. So no matter how you cut it, it's a self-correcting system with very little opportunity for manipulation. We have a BHRS continuation checklist. I included it at the back of the packet so you have the whole thing. I added an item right in here on your packet. You'll see it. It's a request at every reauthorization level to determine whether or not anything has happened in the custody of the child. Because so often families are torn apart by their kids' disabilities. What do we know about shared custody? Both parents have to authorize treatment, not just one anymore. So sometimes, unfortunately, if the father or the mother's not on board, we have to stop. But we don't ever yank the rug out and run away screaming we're not going to work. We'll refer them to a higher level of care. Perhaps that's indicative of a need for family-based. Perhaps the kid's on the greased rails to go to a residential program or something more cataclysmic. So we want to make a cautious, thoughtful, orderly transition from one level of care to another. But at the same time, we can't violate the law and continue to do BHRS on the basis of being a spectator. So we go through this, and this is based on the 4-session rule that the Psychology Association puts out for outpatient psychotherapy. And I turned it into a 4-month rule, because most of our auths are 4 months long. At the end of an authorization period, the BSC, who's got a master's degree, etc., does an assessment of where they think their client is. And they use that to give feedback to the psychologist who supervises them before the psychologist goes out to see the family and does their face-to-face component. So this way the psychologist's not blindly or stupidly going into an evaluation without an adequate understanding of what the dynamics are. If the treatment program has been failing, it will never be rubber stamped for another 4 months. Okay, it's very important that we do that. And finally, we have a childhood trauma checklist that we use for every case because it's no secret. Kids are being traumatized more severely, more frequently, more perniciously than ever before. And we're starting to see lots of kids who are manifesting ADHD and withdrawal and depression, suicidal, whatever, simply because they have been repeatedly, persistently, or egregiously traumatized. And unless you focus on that, you have no realistic hope of remediating their symptoms for a long term. But the other side of that coin, or another piece to that coin, is trauma treatment is not time limited. You can't fit 2 pounds in a 1 pound box. Trauma treatment requires corrective emotional experiences and more often than not necessitates a longer treatment interval than the symptoms would otherwise call for if you can just simply say, oh, it's ADHD. BHRS can work remarkably well and does, in fact, if it's an individualized treatment approach supervised by a licensed professional psychologist directly, not just simply somebody who sees a kid once every 4 months or so. But I see my BSCs once a week in an intensive, at least 1, and sometimes up to 3 hours a week of training, supervision, exchange of ideas, problem solving. The newer ones get 3 hours, the more experienced ones get at least 1 every week. The BSCs are asking the parents every week, how's the kid doing on that Likert scale? And we also inquire of the teachers if the kid's not getting TSS at home. But one of the things you'll notice here on the BHRS continuation checklist is, does the kid get no services in school or no at home? They are supposed to be a unified front. If the kid's only getting treatment in the school, that's a red flag. You mean to tell me nobody ever goes to the house to make sure things are generalizing? How on earth is that a treatment plan? You know, so the BSC hands this to the psychologist, and the psychologist uses this as a sense for the red flags, and it occasions a discussion between the BSC, who writes a lot of the draft psych eval, with the psychologist, who contributes substantially because they're going to the home or the school and observing themselves what's going on. And then they contribute to it and they modify it, amend it as necessary, but ultimately the psychologist is the one who's responsible for the evaluation report. We're all dealing with the same pathetically inadequate funding system, right? It's hard because you're paying them wages that were okay in '92. You know, that's 20 years ago. We offer supervision that is allowing the TSS to get credit in graduate programs for practica and internships. So we tend to attract people who can, you know, who are going to be professionals, psychologists, social workers, whatever. So we tend to recruit those people because they see an added value. I mean, that's one benefit we have because we're a psychology practice. Staff will stay in an organization where they feel they have a mission. And if I haven't convinced you that I'm on a mission, there are children who have autism who don't need 25 hours a week because they're getting a variety of other supports, and what we're contributing to their life has been helpful. That's all. Does it prevent the worsening? Yep. Is it treating their condition? Yep. Does it maintain their functioning at a level comparable? Yep. They meet the medical necessity criteria in 3 different ways, only one of which is necessary. So therefore, do you have a valid prescription? Of course you do. But if you think inside this box, you may not. And that's the point of my presentation at the Psychology Association. I go all over the country talking about this because Medicaid is not a Pennsylvania treatment. It's a nationwide treatment. And the same laws that exist in Idaho exist here. It's again the problem of the box. If you're a prescriber and you think those are your limits, that's what you're going to prescribe within. But when you realize the limits are bigger, then you can prescribe within a bigger box with confidence and defend it. And that's the bottom line people have to understand. It's not necessarily that they're compromised because of who pays them. They're compromised because of their knowledge base. If you work for an organization that tells you the box is this big, you're going to say the box is that big, and you're going to collaborate and cooperate and do everything right within that box. If you know the box is this big, you're going to be much more willing to go a little bit bigger, a little bit longer, a little bit more intensive, just because you know it's not only legal, but it's actually ethically indicated based on national standards. Okay, that's it.